Hello and welcome to Moving Beyond Stigma. My name is Michelle Crossman and I am your host. Today we have a very special guest, Steve Lurie. Steve recently retired as Executive Director of the Canadian Mental Health Association Toronto branch, a post that he held from 1979 to 2020. He is now a Senior Fellow at the Wellesley Institute. Steve has written and lectured extensively on mental health policy issues, and we are very excited to have him here today and chat with us. Welcome, Steve.
Hi, everybody, and hi, Michelle. Wonderful that you're doing this podcast.
Thank you so much. It's been very exciting to get things rolling and talk a little bit more about mental health. Is there anything else you'd like to share about yourself before we get into it?
Well, I guess my background in mental health is related to policy work in relation to the social determinants of health that affect things like housing, poverty, employment, as well as service delivery. The CMHA branch that I led had a very comprehensive range of services, and that included everything from assertive community treatment teams, early psychosis intervention, employment, as I mentioned, supportive housing. But also we found that peer support, both for service users and families, was really important. So I think I bring a perspective about the range of things that make a difference in people's mental health. Mm-hmm. And also some of the work that I did for the Mental Health Commission was national in scope, and I chaired their Service Systems Advisory Committee when they first got started for about 5 years, and that's where we tried to get a sense of what needs to happen to advance a mental health strategy for Canada. And of course it included things like housing, mm-hmm. access to services, those kinds of things. And then what was the Commission's role around knowledge transfer and trying to get people to move in the right direction and not have to reinvent the wheel 13 different times.
Yeah, definitely. That's amazing. All of those things are so necessary, and bringing attention to all the things that institutes do or initiatives do for mental health. I think a lot of times it kind of, from an outside perspective, like if you don't know what's going on and you don't know what's actually being done to help improve the system and help give people what they need, from the outside, it can feel like, not enough is being done because we don't see the whole picture. So I think that's really, really fascinating and important to hear about what is actually being done.
Well, and I think you identify, from the general public's point of view, or somebody who's living with mental illness or mm-hmm. who has a family or a friend, and the numbers are kind of daunting when Statistic Canada used to have a figure that they said, 1 in 5 people will experience mental illness in their lifetime, and that's since been revised to 1 in 5 annually. Mm-hmm. And then, the Mental Health Commission has some statistics that suggest that by the time you reach age 40, and you're nowhere near that, but 50% of people will experience mental illness. If you live to 90, 70% will.
Yes.
And then, if you just think about, okay, those statistics suggest half of us at a minimum will live with mental illness or a substance use issue at some point in our lives. And then you think that we're all connected. So we've got family members, friends, mm-hmm. people we know. And so really the reach of mental illness is much larger than most people think.
Yes.
It's the disease burden is 1.5 times that of cancer, 7.5 that of infectious illness. So, even in the face of COVID, you think about, okay, well, people are worried about COVID, the flu, RSX. But, again, if you have 20% of your population in any one year who are experiencing significant difficulty so that clinically some intervention would make a difference, that's huge. Mm-hmm.
Very huge. Yeah, I feel like everybody I know has a connection to mental health and mental illness, like whether it be themselves or, again, like a family member, a friend. And even when I was younger, like even a teen or my young 20s, that was not the case. Like it wasn't every single person. It was still like a decent amount, but you really notice the difference of how much that is kind of expanded and evolved. And I think our awareness around it also brings that number up, just because a lot of times people would be suffering still, but they just never talked about it. So it was more on the silent side. So then they wouldn't necessarily be included in those stats, you know, because how would they? Yeah.
Well, and that's where, Bell Let's Talk, which is this January 25th, has done, an amazing job in sort of making it okay to recognize that mental health issues are out there and we should be doing something about them. I mean, the paradox with Bell Let's Talk is they do a tremendous job. They raise, in excess of $100 million every year, and people think that's a lot of money. And it is. And they fund projects non-recurring across the country. But the reality is that the work we did at the Mental Health Commission in 2012 suggested that Canada should be spending 9% of its healthcare budget, a minimum of 9%, on mental health services every year. And that's Canada and the provinces. And that equates to about $3.1 billion
wow.
Annually. So that technically you would need to see an increased amount of $3.1 billion added every year over the next 10 years to reach that 9% target. And we're not near that.
No, not at all.
The federal health accord, the provinces are now debating with the federal government, put $500 million in over 10 years, which gets you about 15% of the way. Ontario, to its credit, matched the federal funding, but then you only got 30% of the way.
Right.
So, when you step back and you say, so like, what's going on here? Part of it is the system is underfunded.
Yes.
Secondly, the system was under strain prior to COVID, and with COVID, there's more strain. Thirdly, what you talked about earlier is there really isn't a system out there. Like, so some people go to their family physician. Some people go to the clergy. Some people talk with friends. There is in Ontario, we're fortunate to have Connects Ontario, which is an online and telephone-based listing of services across the province, mental health and addiction services and problem gambling. And for people who need to know about that, it's www.connectsontario.ca. And the thing that's helpful about Connects Ontario is that they can break down the services that are available close to where you live. They also have trained information referral specialists. But I think for the average person, navigating the system, first of all, recognizing you've got an issue, and then secondly saying, okay, so now I need some help. Where am I going to get it? And there's no easy answer. Like the people who are connected to services, like I always considered, the 6,000 people that CMHA served every year, in a city with a population of 3 million, but those 6,000 were lucky because we offered a comprehensive range of services, as I mentioned earlier, everything from peer support to clinical teams. But for the average person who isn't connected with an organization like CMHA or CAMH or even their local hospital or a community-based organization like Loft Community Services, and if people don't even know that these places exist, it's like, how, and that's just in Toronto, it's like, how do you get help for yourself? And then, thinking about the entry point, most family physicians, I mean, here in Ontario, the statistics are, the situation is improving, but most family physicians are still sole practitioners. So it means that your family doc, who's had limited training on mental health, doesn't really know what services are out there. And may not even know what's an appropriate intervention. A good example of that is if you or I went to see our family doctor for the treatment of mild to moderate anxiety or depression, what do you think we'd get?
Probably offered some medication, and that's about
it. Exactly. and that's where the real paradox is, because we know that cognitive behavioral therapy is actually the most effective intervention for mild to moderate depression or anxiety. And we're lucky in Ontario and in British Columbia and I think Manitoba that there's a program called Bounce Back that you can access online CBT resources as well as multilingual telephone-based coaching. And so there's an example that if you were suffering from anxiety or depression, and you thought, well, I'm going to go to my family doc. No, you really don't need to go to your family doc. Go to Bounce Back, and you're going to get a more appropriate service. But how many people actually know that? Exactly.
Not many. Which is, definitely a huge part of the problem. And yeah, I actually had that experience this year. I felt like I needed to change my medication because I was like, I was struggling, things were not going well. So I did call my family doctor to talk about it because he was the one whose name was on the medication. We chatted a little bit, and he's a very sweet doctor, and he was very honest. He's like, I can only do so much. I was like, yes. I was like, but can you get me in to see somebody else? I was like, I know you can't. I was like, honestly, it was like, no offense, but I don't trust you deciding what my new medication change should be when this isn't your area. I was like, I appreciate the offer, but I was like, I don't feel comfortable with that. Are you able to get me in somewhere to see somebody else who can help further? So he did get me in to see a psychiatrist, and then the psychiatrist got me into a DBT group, which was really fantastic, sometimes those wait periods can be very long. I was lucky it was only like about a month before I could get started, so I got very lucky there. But I knew that, I knew from past experiences and other family experiences that my family doctor couldn't actually do that, but I knew he could maybe get me into somewhere. But a lot of people don't know that.
Right, and that's where there's some hope on the horizon. The glass is probably half full rather than half empty, because Ontario is trying to develop what they call a structured psychotherapy program with multiple access points. And so that's where Bounce Back might be the entry point, but if Bounce Back isn't working for you, then you might get referred to group therapy or individual therapy, and there's supposed to be regional hubs developing across the province. But again, without sufficient funding, and that's where you kind of have this arcane debate. It's bad enough that the federal and provincial ministers debate about accountability and just don't. The provinces are saying, well, just send us the money, and the feds are saying, well, we want to see what you spend it on. But unfortunately, we've got professionals who just say, well, just open up OHIP, and that'll make the difference. Well, no, because there are evidence-based interventions that make a difference.
Yes.
So, for example, you had access to DBT. A young person who's experiencing early psychosis will benefit from an early psychosis program which has a multidisciplinary approach. So they don't just medicate the young person. There's talk therapy, there is medication, there's focus on school, there's focus on building the family relationships, and those kinds of things. And in fact, Canada has had a project called Access Open Minds that was funded by the Beck Foundation and CAHR, and tremendous results across the country, and they're now trying to scale that type of intervention up through youth hubs using the approach that Dr. Patrick McGorry developed in Australia and internationally, where a place called Headspace, so sort of a drop-in for young people, low barrier, you just show up, and then depending on what you need, then you're sort of connected to what you need to get. And so, that's, I think, the paradox of the mental health system, where actually there is promising and evidence-based practice. The problem is that we aren't scaling it quickly enough so that most people who could benefit from it would be able to get those services. And that's where I think as Canadians we need to keep the pressure on our provincial and federal governments to say, look, you've got to make the appropriate investments in evidence-based care. I mean, it's interesting, when Jane Philpott was first selected as the Minister of Health in the early days of the Trudeau administration, I had an opportunity to meet with her. And so, we talked about what was the situation in mental health. And I said, well, if you look across the country, you've got provinces who, all of whom have done their own mental health plans, but have never had the money to fund them.
Yeah.
So, maybe there's a role for the federal government here. But I also said that the important thing as well is that the glass is more than half full. You've actually got evidence-based services that you could scale. But you need to make sure that the provinces spend the money on things that will work and that will make a difference. And so, in 2016, 2017, it was a rather tough set of negotiations because the provinces just wanted the federal government to send the money, and Minister Philpott insisted that there would be dedicated funds for mental health. And in fact, the provinces did a terrific job. There, you can go to the Shared Priorities website and see what they propose to spend the money on. But here we are 5 years later having a debate about whether there should be no strings attached money. The provinces have yet to report publicly on what they did with the money they got from the federal government in the first place.
Right.
So we don't really have answers to the questions of, is access improving? Is there more evidence-based service? But that's what people need. It's like when, if you had a broken arm, you would, go to the hospital. They would put it in a cast. They would propose and suggest physiotherapy for you, and over time you'd get better.
Yeah, exactly.
We need the same kind of approach for mental health issues. So, and a no wrong door approach. So if you call 211 here in Toronto, or you call Connex, or you go to your family doc, that there's an easy way to get you into the right kind of service. Yeah,
definitely. I know I have people in my life who have gone to the emergency room at KMH and been turned away because there's no space.
Mm-hmm.
And the amount of strength it takes to, after you would, you say, okay, I need this help, I need to go.
Yeah.
To get yourself up, pack your bag, you go, and then they can't keep you because there's not enough beds. They don't have the space, which is so heartbreaking. But again, that all comes down to not having the funding, not having the proper care just readily available. And then you have to deal with the repercussions of being turned down, even though that's obviously not what they want to do.
Right.
But that's all they have. They don't have anything else, and then that can create such a cycle as well for those who, are trying to reach these places, but then there's not enough of it there.
Well, and I think that's where, again, sort of thinking about what the architecture of the mental health service system should be, because it's interesting. In Madison, Wisconsin, back almost 50 years ago, they developed what now has become known as assertive community treatment, hospital without walls. And that's where if you've got a complex mental illness, you have a team of people around you, a psychiatrist, a nurse, an occupational therapist, peer support workers. We're fortunate we have over 60 of such teams in Ontario, but there are wait lists to get into them.
Yes.
Anyway, when the program was first set up, what used to happen is people would go to hospital, and what they would end up doing is if an admission was required, it would happen, but most of the time they just connected people with these teams. And they found that they didn't come back to hospital because they got the services they needed in the community. And, we did some research here in Ontario looking at the 55 teams Ontario had at the time. And we were able to show that, in the first year before you got sent to an assertive community treatment team, you might spend 50 days a year in hospital. But after 6 years, it was down to 10 days on average. And that was an 82% reduction in hospitalization. And it also showed, we did an economic analysis that showed that for every team that you funded, there was a net savings in reduced hospitalizations of $1.4 million, right? So part of this is to get the architecture right, because most people, if the system worked properly, you wouldn't need to go to CAMH needing an admission.
Exactly.
You'd be able to access the right kind of supports in the community, and that a psychiatric hospital admission would be very, very limited. I mean, there are. It's interesting. There's a good reason to go to Italy if you're thinking of traveling. And actually, I went to I guess about 10 years ago. I went to Trieste because I'd heard that Trieste, which was a city where James Joyce hung out and did a lot of his writing, actually had sort of a state-of-the-art mental health system. And they didn't have any psychiatric units per se, because all the service was in the community. I remember visiting one of their community mental health centers, and a woman came with her 18-year-old son who was psychotic, but the nurse intervened. An hour and a half later, the young man was telling the team to go get him an espresso. I mean, like it was like quite dramatic.
Wow.
They had 4 beds for a population of I think 300,000 people, 4 hospital beds, and most of the beds weren't being used. In fact, half of the beds were being being taken up because one of the community mental health centers had their short stay beds under renovation.
Oh, yes.
So there's evidence that if you put the teams in the community and you take a multidisciplinary approach and you look at making sure people have the range of supports they need to forestall a crisis,
yes,
that's what's going to make the difference. And I remember visiting Japan. I guess that was 2008. So it was interesting because Japan actually has a very high psychiatric bed utilization rate. But when we got to Osaka, Dr. Sawa who was the chief of psychiatry in Osaka, had been to Trieste.
Oh.
And he replicated Trieste in Osaka. And so there was one place in Japan where actually they had low bed utilization because, again, the services were in the community. They had bought up apartment blocks for people, and there was supportive housing, and then their clinical staff made the rounds and made sure people had food, made sure people had their medication, made sure people had something to do during the day. And all of those things made a difference. And so for those folks and their families,
yes,
it meant that having a mental illness, was, yes, I mean, again, if 20% of us are going to have that annually, it's not something to be ashamed of. It's something to live with.
Exactly.
And so in the same way that if, you had kidney problems and you'd go to your GP and you'd get, the right kind of diet and the right kind of medication to deal with your kidney problems, we are still aspiring to have access to mental health services that would provide both appropriate care within primary care, specialized care like psychiatry if you need it. But again, that's where psychiatry can do a lot in the community, and those teams, like I mentioned, the early psychosis teams and the assertive community treatment teams that have access to psychiatry as part of the way they do their work.
Yes.
It means that often it's consultation. And that's where, again, we've got these pockets of excellence across the country. Dr. Nick Cates and a colleague of his, Marilyn Craven, set up a system in Hamilton 40 years ago where the family practices had almost immediate access to psychiatry. And it's one of the only places in the country that's had it as a system.
Wow.
But it means that if you live in Hamilton and you show up at your GP and you're struggling with depression or anxiety or a more serious issue, you can get probably within a half a day, you can get a consultation and probably a visit within 2 days.
Wow.
And so you think about that, and if we had more of those kinds of arrangements, people wouldn't be waiting for hours in emergency, as you talked about, only to
Exactly.
be away, right?
Yeah, definitely. No, that's incredible. I love that they have programs like that. Um, and just like the safety that is felt, when you have a team of people where you're not stuck just waiting and waiting and waiting and feeling
Right.
on your own. You have multiple people there ready to help you, ready to kind of see you through the work, instead of the, hey, here's some meds, maybe try meditating, maybe try this, and good luck,
Yeah. Yeah.
and kind of leaving you on your own. And that's so difficult to just kind of, get yourself up and going. Like you need those people to kind of help motivate you, give you things to do, help push the healing forward. I actually did not know that about Hamilton, so that's really, really,
Yeah. Yeah.
really cool. I love that they have that. That's such an incredible program to have instilled.
Yeah. Well, and I think you talked about, and it's not just having access to clinical services. I mean, we know, and we have known for probably 20 years now, that people being able to access peer support
Yes.
and family support makes a huge difference. There's a wonderful program at CMHA Toronto. You might want to reach out to Jillian Gray to talk about the Family Outreach and Response Program, which has been sort of exported internationally because it helps families sort of take a recovery stance to dealing with their loved one's mental illness, because often families are desperate, especially if they can't get services, and so you often hear things, well, my son or my daughter or my husband or my wife, they have no insight into their illness, and geez, if we could just put them in hospital, that would solve the problem. So a program like FOR helps families both figure out how to navigate the mental health system, but also it gives them hope, and it helps them, and it gives them skills to be able to help their loved one deal with what isn't a very easy and accessible mental health system, and it's skill building on top of the family, and also the families support each other, and you realize that notion of community support is probably a game changer. There's a program in Brazil called Community Integrative Therapy, where a psychiatrist has brought together just regular folks who we all experience, anxiety and
Yeah, for sure.
and it's a non-judgmental approach, but they found, is particularly with what's happened in Brazil, I imagine recently Brazil, the anxiety's gone up, but notwithstanding the attempted coup, what they were able to do in even small remote areas is leverage the power of community to have common sense about here's how you deal with issues. And so that's very much a peer model. Like nobody's an expert
Yeah.
in their own wellness. And so you put ideas on the table. People are free to accept or not. But again, there's been research done on that shows it's quite effective. And so if we were thinking of a system, it would be, okay, so what do we need to make available to folks in terms of peer and family support? And how do we make sure that's ubiquitous? And these days with things like with the availability of the internet, virtual care, technically for peer support and stuff, you don't even need your local supports. I mean, you could leverage supports in Australia, and
Yes,
and so
exactly.
so again, curating what kind of self-help is available to people on their phone. I mean, there's a wonderful little program that you can download for free. Apparently, there's well over 2,000 mental health apps.
Wow.
David Goldblum, who was the chair of the Mental Health Commission and chief clinical advisor at CAMH, told me about this program called WYSA, WYSA, and you can sort of search it online. What's interesting about WYSA is it's actually one of these programs where you put in, you open the link. This little bot starts to ask you how you're doing, how you're feeling, and it's quite remarkable because it's totally interactive. And in fact, when they were designing the program, because it's AI fueled, so they're using artificial intelligence, but they actually had to slow down the process because you would often get a reply to your issue before you'd finish typing in your
Yeah.
But again, things like that, lots of people live on their phones. So like if somebody was feeling anxious, and I've tried it myself. It's a good little program. It asks you questions, it gets you thinking, and they now actually have, if you want to talk to somebody, you can do that as well. So actually, we're into, and this is I think going to be a challenge for provincial and federal governments because we're into borderless mental health care, given the ubiquity of apps and our use of the internet. But that's a strength.
Yeah, definitely.
Part of what's been a problem here is that we tend to have a guild approach. So we won't license different professionals from a different province here, and so psychiatrists want to keep control of what they do. Social workers want to keep control of what they do. I mean, here in Ontario, at least we've got the College of Psychotherapists, which says it doesn't matter where you were trained. If you can meet these standards, you're eligible to practice psychotherapy. But I think we need to get our heads around that we live in a world now where people can go online and find supports. And so what would be really helpful would be to have some curation where, some objective assessment of, okay, well, there's WISA, there's Not Myself and I, and all these various programs. Give them stars or something like that, and some of that could be even done where you engage users, if I used WISA, in fact, WISA asks, it's just they don't necessarily publish their results, but they say, was this helpful? I mean, it's interesting. I have a little program on my hearing aids where if they aren't working properly, I can speak to some AI-enabled bot somewhere, and he or she will make an adjustment in my hearing aid program.
Yeah.
Then he asks me, do you need anything else? Do you want to save this arrangement? And, can I help you further? And so it seems to me we could make mental health care much more accessible to people if we recognized that, yes, ideally people will want to be able to and will need to access in-person services locally.
Definitely.
But at the same time, here's what's available, through the web. And then also, at the same time, build real opportunities for peer and family support in local communities. And that would make a difference for people. Oh,
100%. I feel like that would make a world of difference, honestly. And you could even have like a sort of peer support on these apps, connecting people who are potentially going through something similar so you can, feel heard and recognized and work together. Exactly. And then these kinds of things can also very much help, hopefully shorten those wait lists for the in-person things, because sometimes you don't need that. And then other times you really, really do, Right. So then when we have these different available options that are out there, easily accessible, and offer more, and then we can really, really dive into that. And the peer and family stuff, I fully, fully believe is so important. And, especially being someone who lives in Toronto, and a lot of my friends are artists, and a lot of them moved from far away from their families to then come here, and then they're left with not having their family close, so then they kind of have to build that with their friends. And it can take people a very long time to actually feel safe and comfortable with the family that they built. Sometimes it happens quickly, and you just never know. And having something available that can kind of guide you so that you know how to build that safety with other people, that would be absolutely incredible.
Yeah, well, and there's Cheryl Forchuk, who you know quite well,
Yeah.
has done some really interesting research around using apps to help people with complex conditions manage their illness. And so she did some work in supportive housing in London, where people living in supportive housing units were able to manage how they took their medication and other tasks. And what it actually meant was, the people felt much more empowered. So,
Yes.
yeah, you had to coach them on using the app, but once they knew how to do that, things took care of themselves. People took their medication regularly. People, met their schedules in terms of things they needed to do. And what it actually resulted in was savings to the system, because a number of these folks would need to have, let's say, even a daily visit from an assertive community treatment team nurse for their medication. They didn't need that anymore. The team didn't have to visit daily. So, it seems to me, and the Mental Health Commission has done some thinking on, what does e-mental health mean?
Yes.
But I think we're faced with opportunities where if we leverage e-mental health to improve and increase access, we will be able to see a knock-on effect in terms of, as you've said, people who get the services and supports they need, even on the phone,
Yeah.
Won't need as much in-person care, and then you'll be able to make sure that in-person care is directed at where it would have the most impact. And again, a hybrids will probably emerge. I mean, where we found at CMHA during the pandemic, while we had some very clear standards about when an in-person visit was required, so that if people were worried about a client and they did a mental status exam, and things didn't seem to be moving in the right direction, you masked up, gowned up, and you went and you did a personal visit. But we found that we had peers in Roots in our drop-in center phoning people, once a week, sometimes daily, just to check in on the phone, like a real,
Yeah.
not a rotary dial phone, but a phone. And it made a difference because
Yeah.
it provided that personal contact that you were talking about. Yeah, somebody cares about me. Somebody's interested in what's going on in my life.
Mm-hmm.
And again, so I think the future will be, how do we leverage technology to make mental health supports more accessible to people, but at the same time, how do we make sure that the supports we are providing are evidence-based
Exactly.
and that they're easy to get?
Yeah. Yeah. No, that's so true. Yeah, even just a quick phone call once a week could make such a difference in some people's lives. Just even just hearing the voice, and knowing that they're right there. This is very, very fascinating.
I remember, I guess it was a virtual, was it a virtual conference? I think it was, yeah. A few years ago, there was a presentation on, it wasn't virtual, sorry. It was actually, pre-COVID, and I actually went to this this conference in Washington. But here's the $50,000 question. If you're working with homeless youth, what's the most important thing you can give them? A phone and a data plan.
That makes sense.
Because what they found was, first of all, the big surprise in this particular study done in Chicago was the density of the networks that these homeless youth had.
Yeah.
I mean, but basically they were texting, 24/7.
Yeah.
But that's how they survived. They had people who they maintained contact with through texting. And the one part of the experiment that didn't work was people liked the fact that they could text their therapist and leave a message, but what they didn't like was that the therapists, weren't available to meet at 10 p.m.
Yeah.
So, but at the same time, there's a good example for an at-risk population being able to say, okay, we'll leverage technology, and then listen. And there are barriers for people. Like if you can't afford a data plan on the phone, then you don't benefit from this.
Yeah.
But the ability to be able to text your caseworker, have voice contact when needed, all those kinds of things. Like, again, that makes mental health services more accessible, and you don't have to rely on, I'm only supposed to see my therapist once every 2 weeks, and what happens in between.
Exactly.
I think the future for mental health services is bright if we sort of build on what have we learned about evidence-based care, how do we leverage technology, and what role does that play in evidence-based care, and then also remember that the third leg of the stool is peer and family support, and if you can get all those things to come together, people will be able to experience less mental distress.
Yeah. Wow. No, that's incredible. That was probably my biggest question with the going into using technology more and using the phone was, what do we do for those who cannot afford it? And that's the thing. So I love that that's been already looked into, and thought of, because that's a huge deal. And again, that's something that I feel like a lot of people would not be aware of. They would maybe not know that research is already being done, so that's so important to hear, and so important for us as people who are just living in this world, who don't necessarily have access to all that information, to just understand that people who are in the field are doing as much as they can to try and make a better system. Obviously, there's been a lot of roadblocks along the way because it's not easy, especially when it comes to money and finding all the right places to put our funding. But knowing that people are putting in the work, doing the research, trying to find a better system all across the board for people, and working with the changes that the world has made, even in the last 10 years, things has shifted so much, especially technology wise, and how much we use our phones and all of that. So having that knowledge is so important, because the hopelessness that I feel, some people probably feel all the time when it comes to the system of mental health, and I feel it too sometimes, but so knowing that, there is hope, there is things being done, there is people fighting for everybody, not just those who have the money. They're fighting literally for everybody, is such a big deal. So I very much appreciate you sharing that insight and knowledge. I think it's really important for people to hear.
Yeah, well, and again, I think your listeners should know that, for example, if you're in Ontario, Manitoba, and BC, Bounce Back's there, bounceback.ca, and that opens the door to lots of services. Here in Ontario, as I mentioned at the beginning of the podcast, Connects Ontario is available for people who are trying to navigate that, obscure mental health system out there, because there is a trained information referral specialist who will tell you what services are available. Now, they'll also tell you how long you have to wait.
Yes.
But that's the world we live in, but at least you know.
Exactly, yeah.
And so I think, some of this is, as you've suggested, us getting our heads around, how do we leverage technology? How do we make these systems easier to navigate? How do we support people in the system? And I think there's an opportunity now for the phone companies like Bell and TELUS and Rogers, and with some of their profits, they could dedicate money not just to funding projects, but to making sure everybody who had a mental health issue and couldn't afford a phone and a data plan had one.
Exactly.
Because that's the way you're going to get most people accessing mental health services and really build up capacity.
Yeah, definitely. That would make a huge difference for so many people. All right, this is where we are going to wrap up this episode. Thank you so much, Steve, for coming in and sharing your expertise with us. It was so much information, and it was a very important conversation to be had. Thank you all for listening, and until next time, this is Moving Beyond Stigma.